My name's Javier Rangel, dermatologist and also dermatopathologist. So I get to see patients in the clinic as well as work in the laboratory where I evaluate many of the skin, neoplasms, moles, and melanomas, trying to figure out which ones are benign and malignant. So a different aspect of the care. And today I wanted to talk onto these goals, briefly introducing some of the epidemiology and incidence of melanoma, also going over some of the causes, primary prevention, which is things that we can focus on to prevent melanoma, as well as secondary prevention, which is early detection. And so that's where the screening and surveillance comes in. And just briefly at the very end, touch upon the Kaiser Permanente way. So something that we're really working on at this moment. That's something called precision tracking program. So just touch at that at the very end. And so this is one of those slides that that's something that introduces the rate or the incidence of melanoma that's happening or projected for 2019. And as you can see in that first number, over 96,000 new primary invasive melanomas that are estimated to occur in 2019, and that's higher than last year for many unknown reasons as well. The other number, 7,000, a little over 7,000, that's the number of deaths projected for melanoma for this year. And thankfully, that's almost 20% fewer than last year. And that could be for many of the treatments that are being touched upon on this in this conference. And so to put it in perspective, the comparisons of these skin cancers, basal cell, obviously, squamous cell, the most common and less aggressive of the skin cancers, much more frequent in incidence. And you can see that melanoma is really at the bottom of that triangle, 96,000 cases. However, really constitutes most of the deaths from skin cancer. So really something that, obviously, this foundation is focusing on and a lot of clinicians are working on. A little bit about the epidemiology. 1 in 40 white persons in the US, United States, are estimated to develop melanoma in their lifetime. And 1 in 200 Hispanic or Latino or Asian individuals, and about 1 in 1,000 African American persons. And obviously, some of the risk factors for risk of death include male, older age, so if you're over 50 years old, if you're white, if you live alone, and also if you have things that predispose you to immune deficiency, such as organ transplant, which is becoming more common. So some of the causes, obviously, these are things that you'll see in the literature, in magazines, and also talked about by your dermatologist, which is me. Ultraviolet rays really is one of the main, sunburns, one of the main causes of melanoma. And, just really breaking it down basically, ultraviolet B, it burns, sunburns, wrinkles, ultraviolet A, DNA damage, and that's where tanning beds come in. And so I'll touch upon that as well. What happens with the genetic evolution of moles? And this is something really interesting that, that was just published just a few years ago by the UCSF group, Dr. Bastian and colleagues. They really developed a model in terms of the genetic evolution of moles to atypical or dysplastic nevi to then melanoma, the pre-invasive type, the melanoma in situ, and ultimately to invasive metastasis. And as you can see in that second row, the point mutations, you can see that they increase almost linearly as you go from benign to an atypical or intermediate lesion to then a pre-invasive melanoma, then melanoma in situ, and then ultimately increase substantially with the invasive and metastasis numbers. The copy number alterations, which is increase in certain genes, that is a later event, so more associated with invasive and metastasis. But you can see that most of those mutations, they're ultraviolet radiation signatures. So they have like a specific, CC to TT mutation that happens that they can tell is from ultraviolet light. And most of those mutations are coming from those ultraviolet rays. So that really goes to show that ultraviolet light and minimizing those harms is going to go a long way to preventing this evolution of these lesions. And as some of the speakers have touched upon with the driver genes, the BRAF, the TERT, these are mutations that happen pretty early on. So a lot of benign moles, you can see BRAF mutations already. And it's really the accumulation of these genes and these mutations that then progresses to the invasive melanomas and metastasis ultimately. So just wanted to touch upon that, the basic science there. As well, but so the focus really is primary prevention and what lowers the risk of melanoma or developing melanoma. Obviously, sunscreen, and I'll touch on a study on the next slide. Avoiding tanning booths, really important. Performing skin exams regularly. If you have a partner, somebody to look at your back, and I always tell people to take photos of their back, have somebody take a look, help them out. And having a physician look at your skin, really, in the last 3 years has been shown in a study to reduce the incidence of melanoma or invasive melanoma. So if you're going for your annual checkup, you're already seeing a dermatologist, you're seeing an oncologist, you're seeing physicians regularly. You go in and just undress, take off your shirt, have them look while they're listening to your lungs, your heart. If they're looking at your skin while they're using the stethoscope, they could detect something as well. So really, the more eyes, the better. And primary prevention, really, again, sunscreen, sun avoidance. And this is a study that was done in Australia, randomized trial, where they gave participants sunscreen, other participants, they did not, and so they followed them. And really, it's been shown to decrease the incidence of invasive melanoma. And just a little bit personal note about the tanning booth. It was really funny because I moved to Philadelphia for my fellowship, and first time moving to the East Coast, never lived there before, and looking at apartment buildings, they're walking me around, showing me the gym facilities, and a few of them had swimming pools, and many of them, I was really shocked, had their own tanning salons that were amenities, free amenities for the residents. And I was like, oh my gosh, you're telling the wrong person. This is the worst thing ever. So, really, it's like, please avoid tanning. Like, this is not something that's really, not at all good for your health. And so I ended up going with an apartment that did not have a tanning salon. Yeah. But, really, skin cancer prevention, I can't focus, and say it enough. Sunscreen and, SPF 30, that's the new minimum. You can't even call it sunscreen if it's SPF 15 anymore. So really 30 or higher, broad spectrum with UVA, UVB coverage, water resistant, obviously. And if you've never had a melanoma, obviously, tailoring it to your, what type of activity you're using. But if you've had a melanoma, really, please use it every single day. I put it on this morning, even though I'm coming indoors. But use it every day, the sun-exposed areas, the backs of your hands, arms, your face, and make it part of your routine. I put it on right after I brush my teeth. It's a daily routine. It's ingrained, and you just have it on. And really, it goes a long way. It really goes a long way for many, many different reasons. As far as self-screening, the American Academy of Dermatology, they have the campaign spotskincancer.org, really shows you the schematics and drawings on, how to perform a self-skin exam. Something you could do easily after the shower once a month. And then for, African American and Latino Asian patients, looking at the palms and soles on your birthday. These are just pictures of incidental melanomas found during a routine physician wellness exam, and there's many different colors and variations of melanoma, but these are some of the things that we commonly see in the dermatology clinic. So how do we find melanoma in the population? And this is something that's a little controversial still. Population screening for colon cancer has grade A recommendations, for certain age groups, 50 to 75. But when it comes to skin cancer, population screening really hasn't been given that grade A recommendation. I mean, it's a grade I insufficient. So the jury's still out. This is something that's work in progress. There's many dermatologists that are have critiques about the way this was done, but for now, population general screening of all people is not recommended, and it's really, for patients that have symptoms. However, targeted screening of high-risk population, groups is, can result in a benefit. So, routine screening, it lacks a proven survival benefit, but melanoma survivors really, it's really among the highest risk group, and these are some of the studies. One by Dr. Maris, second primaries. Another one by one of my dermatology colleagues in Walnut Creek. Multiple primary melanomas among Kaiser cohort, and really the risk of a second melanoma after already having one melanoma is somewhere in the ballpark of 6 to 12% among the various studies, and really the highest risk is in the first year. Usually after an invasive melanoma, the second one is of lesser thickness, and patients often do about as well if they have multiple primaries versus a single primary. But the risk goes on 1%, for each year, and it can go, the Kaiser study went up to 15 years risk every year, 1%. And so, screening of patients is important. And there's this study by the Memorial Sloan Kettering Group screening patients for at stage three patients, which are higher risk for recurrence after surgical, resection. And they studied the areas and how the areas in which, and also how recurrence was detected. And systemic relapse was really the most common. And really, what I found very interesting about this was most often it was detected by the patient and the family, and 47%, much more than routine imaging or the physician, surveillance. Most were detected within 3 years, the first 3 years, and the risk really lowered after that, after 3 years, to less than 5%. But, so physical exam and imaging beyond 3 years is unlikely to detect first relapse. So first 3 years are really, really crucial. And a Spanish study of intense surveillance imaging, 39% developed metastasis, and again, just another time point, 1.4 years was the median. So the recurrence in these high-risk patients happens somewhat earlier rather than later, and so the American Academy of Dermatology has developed guidelines. We have our guidelines we've adopted based on these in terms of surveillance, and obviously with frequent skin surveillance and skin examination, comprehensive history, physical, lymph node exam, and then imaging that could be optional for certain higher risk groups as well. So really the rationale that I've been trying to point to for intensive screening and surveillance is patients are at high risk for relapse, obviously, mortality, additional primaries, and ongoing screening is really needed, close coordination of the care among all the providers. So really engaging dermatologists like myself, the surgical oncologist, the medical oncologist, and really ultimately to detect recurrences and new primaries at an earlier stage. Ultimately with this prompt diagnosis, we can improve survival and quality of life. So a little bit about the Kaiser Permanente and something that we're doing. Kaiser Permanente is a really large group, greater than 4 million Northern California members, and we're fully integrated. And we have an emphasis on prevention, and we use care pathways, electronic health records to take care of our members. And so we have a multidisciplinary committee that's adopted these guidelines, these national guidelines, and adapted it to our population. And we have a large team of analytics and operational, obviously clinicians, and we can develop tools to really track patients virtually And there's a precision tracking team that's really involved in this, tracking the patients virtually to make sure that we meet these surveillance follow-up goals, to make sure people don't fall through the cracks. And that's something we're really working on to make sure that we have, prevention at our first and foremost. So, as I mentioned in the previous slide, improving quality of care really is one of the goals of our precision tracking and communication, coordination, ensuring patients, meet these nationally recommended guidelines for surveillance and detecting new primary melanomas because, like I said, second and multiples are common, and detecting recurrences as well, and really improving survival is the ultimate, and quality of life is the ultimate goal for this. Just like to thank some of my colleagues, Dr. Patrick McCluskey, a dermatologist here at Oakland. He helped me with several of the slides. Our dermatology chiefs, Nok Pham and the Melanoma Working Group, obviously, Thak Yao, and the tumor board for inviting me here, and my wife and family support and all this. Thank you.